Greetings, everybody. This is Steve Cole with your PARM 2223 lecture for Unit 14. And this lecture, like the whole theme for this week, is going to cover, well, pretty much mental emergencies and behavioral emergencies. And this particular lecture, we're going to talk about issues with restraint, liability, and so on and so forth. So this lecture does drift into the clinical a bit, but it's as much a medical legal lecture as it is anything else. And again, these are a lot of things that I wish I had known when I started paramedic program, which I had to learn through trial and error in the hard way. So let's get right down to it. So here are some of the things we're going to talk about. Again, there is a little bit of clinical, but there's a lot of street tips in this lecture. There's a lot of legality and medical legal. And I think that by the time you're done, be like, darn, I really am glad I sat through that. Now, you'll find a lot of stuff that your field providers that you work with may not agree with. And that's, I don't want to say that's okay, because I think a lot of this is pretty cut and dry, but everybody practices on their own. But these are things I think are really important. So at least absorb them and consider them. All right, let's dig in. So just fair warning, I have, full disclaimer, I've been that guy. And by that guy, I mean the guy that went downtown when he was a young, fresh new paramedic with a vial of Haldol and a syringe and a needle in his pocket, ready to go wrestle the drunk guy down and have the rodeo. Matter of fact, when I started in Tennessee, there were people that prided themselves on how many combative patients they had in a weekend. There were also people that prided themselves on how many fights they got into a weekend with paramedics and EMTs. I am not kidding. There was a guy that every full moon would call the sheriff's department in rural Cheatham County and said, "Hey, I'm that guy that you got a warrant for. I'm drunk. You all better come get me. You better bring a can of whoop up with you." And of course, they'd call up all the rough and rowdy deputies, and every full moon, they would go out there and tussle with this guy, and it was a fun time to be had by all. And of course, we were always involved. That's just the way it was, wasn't it right? That's just the way it was. So I've been that guy. And then as I learned more and learned better, I hopefully did a little bit better. So that's what we're going to do. Is we're going to talk about the legality of what we can and can't do. And then we're going to talk about some street tips that I've learned over the years to help me better negotiate so we don't have to get into the fight. And I hope those are useful for you too. So how many of y'all, as you ponder this, have heard the idea that if we take somebody, if we restrain somebody or whatever, and we aren't doing it right, it's kidnapping? Which sounds pretty bad. Now, I'm not going to say I'm 100% right on this, but I have not yet found a case where EMTs have been successfully sued for kidnapping. However, there are plenty of cases that we have violated somebody's constitutional rights and have been held accountable for that. And we talk about constitutional rights, I'm talking about the Fourth Amendment. Now you think, okay, where does the Fourth Amendment come into play with medical care? Isn't it about warrants, and isn't it about probable cause and due process? And yes, it is. But also has to do with the Fourth Amendment has been extended through the Supreme Court to extend to medical decision making. And when we talk about searches and seizures, we are talking about seizing somebody's body in this context. So when we talk about this, keep in mind that especially when you're running 911 calls, you are in essence a de facto state actor. Now, when I say state actor, I don't mean you're up on Broadway in a play. You are acting on behalf of the state, meaning the government. And therefore, you have certain constitutional obligations that actually are more stringent than if you were a private entity performing care. And a lot of those apply to restraints. Now, legally, this is the definition from CMS. Restraints are any physical or pharmacological. Or pharmacological means to restrict a patient's movement, activity, or access to their body. So when you are blocking a door, from CMS's perspective, from legal perspective, you are providing a form of restraint. When you are preventing them from doing things, you are providing a form of restraint. With that in mind, the next step of this, you have to understand that patients have a right to move. They have a right to activity. They have a right to access their body. They have a right to leave if they want to, except in very specific situations. So when you inhibit that, you are infringing on their rights. They also have a right to be free from restraints unless restraint is absolutely necessary to treat their medical symptoms or to prevent the patients from harming themselves or others. And those are the criteria that we as healthcare providers can intervene. And even then, we're going to narrow it down a little bit. That is, so committing a criminal act is not our problem unless it's hurting themselves or others. We're not in most cases, I should say, unless you are in a dual service, a PD and EMS agency. There's still a few of those out there. In most cases, the legality of it isn't our issue. It's when they are taking actions that we can reasonably assume might harm themselves or others or ourselves. So let's take this a little bit further. As a matter of law, any individual who chooses to restrain somebody else may be found responsible for the intended, and pay close attention to this, the unintended impact, especially as state actors. As a matter of law, any individual who chooses to restrain somebody may be charged and found responsible for the intended and unintended impact. For example, if you restrain somebody and in the course of that restraint, a patient's arm gets broken, or they suffer a restraint-related aphyxic death, or anything in between, because we were acting on behalf of the state and engaging them, we are potentially responsible for that. Now, does that mean we will be? Well, that depends on the circumstances. We're going to talk about that in just a few minutes. But you have to understand that you can be held responsible for the unintended impact. And here's another thing, and I don't remember if I have this clearly spelled out later in this lecture. Even when you do restraint perfectly, when you follow all the best practices, and when you do everything you can to mitigate the risk, these patients can still die. And I think that's important to understand. This happens a lot more than you hear about, especially with custody, both in mental health institutions and incarceration or the prison institutions, as well as in healthcare. And it happens a lot more than you hear about. So this is EMTALA, that patients have a right to be free from any physical chemical restraints imposed for the purposes of discipline or convenience and not required to treat the resident's medical symptoms. So I want you to think about this. There have been, and there still are cases, and it used to happen a lot, where patients would be sedated not because they were combative, but because of staffing concerns, because the staff didn't want to deal with them throughout the night. They would be restrained because staff didn't want to worry about them getting up and wandering around, because staff just didn't want to deal with them. And this, again, I'm talking about nursing homes. I'm talking about mental health facilities, and et cetera, so forth, even hospitals. This used to happen a lot, so much that it became an issue that the federal government stepped in. You see that at the Consolidated Omnibus Budget Reconciliation Act of 1987, which amended EMTALA in many other different ways as well. So, keep that in mind. That we can't tie people down just because they're pissing us off. We have to have an articulatable, something we can write down and sound intelligent is another way to consider articulatable reason to put our hands on these patients. Now let's talk a little bit further. Generally, this is actually a circuit court decision. I almost said Supreme Court. It's actually circuit court. But it is not a constitutional violation for a state actor, i.e. you and me, to render incompetent medical advice, or fail to rescue those in need. Now, I want to illustrate that. Doesn't mean we won't be civilly liable in other means. That's not what I'm saying. But as far as constitutional, the reason I talk about constitutional violations is constitutional and civil rights violations have the highest penalties. This is where the Supreme Court gets involved. This is where the real law gets, the legal precedent gets established. This is the big leagues. We don't want to be up here. When we get into constitutional violations, civil rights violations, and statutory immunity we have at the lower levels goes away. Now, there are two exceptions to the legal principle I just cited. Two legal principles, and one is custody, and the other one is state-related or state-created danger. Now, the reason I talk about custody is that when you take somebody, and I think I say this on the next couple slides, when you take somebody into custody, you are assuming responsibility for their safety. So if you've assumed responsibility for their safety, you are responsible for their safety, and includes their life safety. State-created danger, the argument here, and it has been used, is that when we lay hands on patients, we are creating an element of danger. Because we know that restraining patients in and of itself is fundamentally a risky proposition. Now, sometimes we need to. We don't have a choice. But there is always an elevated risk. And you don't have to be a law enforcement officer for this to apply. You don't have to be a sheriff's deputy. You just have to be either a governmental employee or acting on behalf of the government. So if you work for a private organization who is therefore contracted to do 911 work, or has an agreement to do 911 work, you are de facto a state actor. Matter of fact, there's some argument, although I haven't seen it firmly decided, that if you take federal monies, you may be considered a state actor as far as Medicaid is concerned. But I don't know if that's 100% accurate or not. So where's the balance? Well, the balance is you have to balance the patient's individual rights versus their safety and public safety. And it's not a clean balance. It's not perfect right or left, or one side or the other. Sometimes you're damned if you do, and you're damned if you don't. And when you're faced with that situation, you always want to do what's in the patient's best interest. So, some basic guidelines when dealing with patients who are suffering a psychological crisis. Well, first of all, your safety comes first. And I'm not one of these guys that says, well, BSI seems safe, and if the cops aren't there, don't go in. Although that's usually the case. And the reason why I say that is I think that's too simple of an answer, too simple of a way to look at this. I've been assaulted a number of times on the job, and every time I've been assaulted, law enforcement was already there. Every single time. Or it was a call we wouldn't normally get law enforcement on, like hypoglycemic patients. Those are those are always bad news. So, if you keep in mind that if you don't have the resources to go in, and you go in and things escalate where they could have diffused themselves before you go in, you are in some sense creating this state danger. If they are agitated and pissed off inside, but they're sitting there by themselves and they're not effing with anybody, wait till you get the backup, okay? There are times when we have to go in where there's an imminent threat. If you're a firefighter, sometimes you have to go into the fire if there's an imminent threat to life safety. Sometimes that exists, but those cases are exceedingly rare. Before you go in, listen at the door. Listen at the door before you actually enter a residence. As a matter of fact, I even say when you approach a residence, you look for what I like to call threat cues. Little things that tell you things might be amiss. Beer cans, poor repair of the residence, screaming and yelling from inside, stuff of that nature. But listen, before you go in and find yourself in a situation you have trouble extricating yourself from. When you go in, keep in mind that patients respond to the tone of your voice. Now, in law enforcement, they have a consideration called verbal judo. But we're not cops, so I like to say that we have verbal aikido, in that it's always good to convince the patient to do what you want to do, but make it sound like their idea. And we'll talk about some of those strategies. When you're approaching a patient, make eye contact. A lot of times what you see in their eyes will tell their intent, and what you see in their hands will tell their next action. So make eye contact, look at their body language. And keep distance, and I'll talk about that in a few minutes. And show empathy. Now, a lot of people consider empathy with sympathy or lying to the patient. They're not exactly the same thing. When we talk about empathy, you're letting people know that you are engaged with them. You're letting people know that you are there to help them as much as you can. So listen to them. Don't cut them off. Listen to them and what they have to say. Feel free to validate what they're saying. Now, validating doesn't mean you agree with them. Validation just means that you accept that their situation as they perceive it is pissing them off, or is upsetting them, or is scaring them. So I would not participate in their hallucinations or delusions. I'll tell you a great little story. I used to work with a gentleman, very cool cat, great paramedic, and he participated in this patient's delusions and hallucinations one time. We're transporting him on a 45-minute transport, and this patient had delusions of persecution, had voices in his head legitimately. And my friend Pudgy was his name. That was actually his name. Was sitting there talking to this gentleman and would be like, oh, well, so those voices say that. Well, tell me all about it. And, oh, really? Well, yeah, you're right. Those voices are just, going on and just having a grand old time. It was, as a brand new, I wasn't even a medic, I was a paramedic student at the time, was hilarious because he had the gift of gab, and we all know people like that. Until suddenly the guy looks at him and goes, now that's strange. Why would they say that? And Pudgy looks at him and goes, say what? He goes, why would the voices tell me to kill you? You've been nothing but nice to me. Suddenly, engaging in his hallucinations and delusions wasn't a great idea. So, also keep in mind that sometimes when patients hear these voices, they still know they're not real. So by engaging in them, you are compromising your credibility to these patients. They will have moments of lucidity when they realize you're just screwing with them. So just don't do it. Use positive and helpful statements. I want to help you. Help me more. I try not to sound like Jerry Maguire. Help me help you. But it's okay to say, I'm here to help you. I just don't understand this. Help me understand this. Put yourself in their position, trying to help them find a solution to the problem, if possible. Even if it's just a short-term solution of, let's go to XYZ location so that we can get you more help. So we've all been on those cases where, it's the intoxicated guy standing in the alleyway, and we're standing over him, and we're kind of have that 3 a.m. I'm irritated look. I would suggest that perhaps you could take a different approach. Like this gentleman here. This is a paramedic with Rural Metro, and this gentleman here is one of their most frequent flyers. If I recall correctly, let me look at my notes here. This gentleman had called, I don't have it in my notes here, but over 300 times in a certain year. And with that in mind, this paramedic who is on their community response team knew him very well. So I want you to take a look what's going on in the front, foreground, and the background. Now in the background is his partner. Close enough to act, close enough to help if needed, but far enough back that he's not crowding the patient. The other person, who's a fireman standing behind him, is not in this guy's grill either. He's giving him some breathing room. Sometimes when we show up on scene, we got 3 guys kind of dealing with the patient. One guy's putting on blood pressure. One guy's asking them questions. The other guy's taking a pulse and doing whatever, and we kind of crowd their space. And if you're already on the verge of agitation and combativeness, that can tip you over the edge. So everybody else is kind of stepping back, and one guy's engaging them. If you are in a delirious or you're in a crisis mode, focusing on one person is hard enough, much less focusing on 3 or 4. So give them just one person to focus them. Now, I want to point out something else. Now, this guy is a little bit closer than I would like to be, but other than that, and that's just maybe he has to do that to show empathy, but he's off to the side. One of our biggest defenses against assault is time and distance. Distance, the distance they have to cross to actually engage you physically, and time, the time it takes to do so. And by being off to the side, he adds half a second to that reaction time. So that's just another little thing I like about this picture. Now, I like tacos. You're probably thinking, tacos? Yes, tacos. I like tacos. But there are some things that I'm sure we've all done that we should avoid, and the abbreviation for those are tacos. What to avoid? Don't threaten a patient. Now you think, well, I would never threaten a patient. Well, you might not realize it. Don't threaten a patient. Say, listen, you either come with, if you don't shut up, this officer is going to arrest you. Well, A, officers hate that. And B, it's a threat you can't follow up with. And even if you threaten them, once you threaten a patient, you can't go back. Once you're the bad guy, you can't be the nice guy again on that call. You can't. So just don't do it. Don't try to argue or contradict a patient. That doesn't go anywhere. That's just going to escalate things, especially if they're in a delirious state. If they could have talked themselves out of it by now, they would have. Your ability to reason them through is going to be very minimal. That's, again, where verbal aikido comes in. You try to redirect them, but not argue or contradict them. Don't challenge the patient. And by challenging, engaging in power struggles. Why? This is my scene and I'm the one in charge, so on and so forth. Again, that's not going to de-escalate the situation. Don't be rigid in your process. Some of us are like, well, some of us are like, well, you have to sign this and you have to do this and you have to answer my questions because I need these questions answered. Well, you do need those questions answered. You do need your vitals done. You do need this. But there are ways to get that done without making it a push-pull power struggle with you and the patient. Avoid raising your voice, making threats, giving ultimatums. It's my way or the highway. Avoid standing over them. Law enforcement has gotten a lot better about their field interrogation positions that are both non-threatening yet tactically sound. So pay attention to the good officers and see how they engage patients. And here's a big one. Don't shame or disrespect the patient. Yes, they may have defecated all over themselves. Yes, they may be drunker in snot, and it's the 5th time this week they've been drunker in snot. Yes, they may have beaten their wife. Yes, they may have refused to take their meds. Yes, you may be very frustrated with them. But telling them these things is not going to get them to where they need to be any quicker. If any of these methods worked, I'd be the first to tell you, yeah, go ahead, threaten the patient with jail. He'll come right along, but it never does. It never does. And if it does ever work, I bet it only works once in a career. And the other 2,000, 5,000, 10,000 times you may encounter these psychiatric patients, they won't work. So, remember that when you're listening, okay? You're not thinking to respond. You're not thinking to contradict them. You're not cutting them off. Multitasking is not good when you're listening. Let me give you a prime example. If you have a teenager and you're talking to them and they're looking at the phone, does it piss you off? Absolutely it does, because what you say is important. So why would you think that your patient would not get irritated if you're looking down at the tablet and you're doing other stuff like that? If possible, have the captain, have somebody else do it. If that's not possible, here's a news flash. For the first 20-some years of my career, I didn't have a tablet to write down on, and I didn't use a pen and paper. I kept it in my head and then took notes afterward. When you're engaging with a patient, engage with them. Okay? Again, body language is important. Don't crowd the patient. Don't stand over them. What is the tempo and tone? Are you sympathetic or are you domineering? What is the appropriate method? Now, you'll have some people say you need to have a command voice, a command presence, so your patients don't take advantage of you. There is a time for what my wife calls her mom voice. There is a time for your military voice, your military posture, so on and so forth. But again, it's kind of like being the asshole. Once you do that, you can't go back. So don't start with that. Don't lead with that. Because you'll miss an opportunity to have a much easier time with the patient. Be patient with the patient. Some of these calls, if you say, okay, man, this is a drunk, we're going to be 10 minutes in and out. This is a psych patient, going to be 10 minutes in and out. You're rushing, and you will escalate the situation, not de-escalate it. De-escalation takes time. These are 35-minute, 30-minute, 45-minute calls, sometimes longer. But they are calls that if you can de-escalate them, you avoid a lot of the pitfalls we talk about when we talk about restraint. If you can de-escalate them, get them to come along with you and cooperate, or at least be non-combative with you, which may be a win, if that's all you can get, then that is always a better option than taking them to the hospital, having them pissed off, and then just ended up in a big tussle in the back of the ambulance. Every time. So here we go. This is another picture from the same documentary. Now, this is a little bit different. I won't point out. This is the same gentleman. Now, I want you to take a look at him. I want you to take a look at the way he's looking at the provider with the sunglasses on. And I want you to take a look at what the partner's doing right behind him. Now, we all have been in a situation, but does he look like he's calm? Not at all. A, the guy isn't making contact on. He has his sunglasses like Tom Cruise. And we've all been there. B, he's got the guy from behind him crowding him. He doesn't even know what's going on. This guy's reaching over. The tempo, the body language, everything is somewhat escalated. Take a little time. Avoid the fight. Your life will be a lot better. So let's talk about actual restraint. And a lot of this is, some of this is really just tips I've learned over the years. So let's talk about scene safety. Keep in mind that what I like to call the search rule, not all searches are created equal. So if you talk to law enforcement, the level of detail they get into a search when they detain someone, and the level of search they get into if they are actually arresting someone to go to jail, are two different things. So somebody might get a brief pat down while they're being detained, waiting for medics to show up and check them out and take them to the hospital, versus somebody getting searched extensively before they get put into the back of their car for transport to the jail, where they'll be searched yet again. So keep that in mind, that just because law enforcement has somebody in handcuffs or is already on scene, A, doesn't mean they were searched at all, and B, doesn't mean they were searched well. So don't be afraid to say, hey, have you patted this guy down? And don't be afraid to say, hey, can you check him again? Now, there's something else in law enforcement called the +1 rule. When you find a weapon on somebody, whether it's a screwdriver carried for violence, or whether it's a pocket knife, or whether it's a gun, assume that there's always a +1 more. There have been plenty of cases where they found one pocket knife and missed the gun, or missed another weapon of some sort. So, look, if you find somebody with weapons in their car, assume they might have them on them, so on and so forth. Be diligent. Really cautious around certain locations, particularly bedrooms. Why bedrooms? Because people have guns in their bedrooms. I have guns in my bedroom. I have firearms in my bedroom. They aren't always secure. We go in on diabetics. We go on confused patients. We go in on all sorts of situations, people's bedrooms. They are confused. You're in their most personal spaces. It can get violent real quick. I'm also concerned about around kitchens, because kitchens are full of sharp and pointy objects or heavy frying pans. I'm concerned around cars, because people keep weapons, in all sorts of nooks and crannies in their car, including firearms. And I'm worried about garages, because again, when you are in garages, there's all sorts of sharp and pointy things. Now, one of these, the Kramer corollary. Jason Kramer was a guy that used to work with us many years ago. And he'll tell you a great story on how They sat a diabetic down on the couch and thought everything was fine because he's wearing just his underwear, and they put him on that couch until he reached into the couch and pulled out a hand cannon. If you're going to put somebody somewhere, have them sit down somewhere. Make sure there are no surprises where you place them. And what I like to call the cold corollary, from my own personal experience, there's been a couple times where a patient became suddenly and acutely agitated in confined spaces, where I wish I had moved, before I engaged in a patient who I knew was agitated, I wish I'd moved that chair out of the way, or I wish I'd moved that table out of the way, or whatever the case is. Because those things you can hurt when you fall into them, let me tell you. If you're gonna struggle with someone, if you're gonna put your hands on someone, let it be on your terms in a space that you identify, if possible, and make sure that I don't like to use the term battlefield, but make sure the playground, so to speak, is one of your choosing, not the patient's choosing. Now, we talk about the approach rule, and I already mentioned this. If you're going to approach a patient and you're going to talk to them, especially if you aren't so sure about whether they're going to get agitated or not, do it at between 45 to 90 degrees of the patient. 45 to 90 degrees of the patient. So then, not only do they have to cross the distance, whatever the time it takes to cross the distance, but they also have to turn and face you, which adds a second to half a second to a second to do so. Time and distance is your friend. Something called the prison crouch. Sometimes you'll walk up on a patient and you'll see them kind of crouch down, leaning against a wall. If they've been to prison, this can be a tactic, because what it does, it gives them a position of advantage, surprisingly, where they can leap out and take you down at the knees. So keep in mind that before you approach a patient, keep in mind it's not just what they can reach, it's what they can lunge. So when you close within their height, so to speak, 6 feet or less, make sure it's on your terms if possible. So another thing to keep in mind is we are not cops. And the patient, while they may have been engaged in criminal activity and they may actually be criminals, for us, they are patients first. When you find combative issues, always assume that may be a sign of an illness or injury, not simple intoxication. Keep in mind also that restraint for legal and criminal and law enforcement reasons, not related to patient safety or medical care, is not our deal. If any restraint for legal reasons, i.e. they're committing a crime, if it's not directly threatening us or somebody else or harming themselves, it's a law enforcement issue. Don't get your roles mixed up. If you do have to restrain somebody, it's a team effort. Make sure everybody knows what they're going to do. Most law enforcement officers will engage in a restraint with, usually, unless it's a real tussle, with just 2 people, because they know the more people you get involved, the greater, statistically, the greater the chances somebody's going to get injured, whether it be the patient or one of the law enforcement officers. They've learned that lesson the hard way over decades of experience. And that's why they train taking people down with just 2 people. We don't train nearly enough on that. But so just the old method of dogpiling on the patient is a good way to get hurt. So if you're going to engage in somebody and you have time to briefly brief it out with your crew, do so before you put your hands on the patient. Now there is plenty of discussion and position papers and on restraint ad nauseum. Now, the one thing I'll tell you is that you should be familiar with them, because these are the things that they're going to bring up if things go sideways. They're going to look at this position paper and say, hey, here it says you shouldn't do X, Y, Z. Why did you do X, Y, and Z? Well, because my FTO said that was okay. Well, that's not going to cut it. Okay? So pay attention to that. Keep in mind that, let's talk about when restraint is indicated. It's indicated when a patient exhibits a behavior, for whatever reason. A behavior in the loose sense could be agitation, combativeness, or psychological issues, that's associated with increasing risk of death, injury, pain, disability, or causing death, injury, pain, or disability to another person. When it interferes with you taking care of them. This is an important one. This is what you'll be judged by. If you do have to restrain somebody, was it applied as humanely as possible with only the minimum amount of force needed to effect the restraint? So if you get into a tussle with somebody and whip out your D-cell maglite and tonk them over the head, was that the minimum amount of force you needed to effect medical restraint? If you beat them over the head with your oxygen cylinder, was that what you need to do? And considering that could have lethal outcome, your life had better be in imminent articulatable danger, or somebody's better be, if you decide to take that route. Honestly, they're going to look at, just like lethal force for an officer, if you injure somebody with a weapon, they are going to look at that with exacting detail. So my advice is use the least restrictive but effective restraint possible. And this isn't the lawyers saying this. This is the American College of Emergency Physicians' use on patient restraints, particularly in a pre-hospital setting. These are the medical directors in EMS agencies across the nation. So let's talk about what the ideal restraint is. This is a picture-perfect world. You have one arm up, one arm down, straps over the patient so they can't wiggle, and you also have the only thing you can't quite tell here is that his feet are also restrained. Not all patients will just lay down and allow us to do this. So here is what you're looking for. You want to make sure the patient cannot wiggle their way into a position to harm themselves, either by accident or on purpose. So we don't want them to wiggle into a way that they're actually going to choke themselves by accident. Especially we don't want them to fall off the gurney. So if you have somebody that's struggling on the gurney, even if it's on smooth pavement, have somebody on each side of the gurney as well as on each end. Because what will happen is their shifting weight could tip the gurney. If they fall because they're restrained, and you created the danger by making them restrained, you are now responsible for the pain and injury they suffered. Very big thing. No prone restraint, period. I didn't really plan on spending time on positional asphyxia in this lecture, so I'm not really going to spend a lot. But positional asphyxia is a thing. Yes, it's complicated by drug use. Yes, it's complicated by exertion. Yes, it's complicated by hyperthermia, hypoxia, and hypercarbia. Absolutely. But it's also can occur absent of those, especially in the morbidly obese. Do not restrain patients prone. If you go up on scene and they have been hobbled and they're in a prone position, which rarely happens anymore because most cops are hip to the jive, roll them on their side. You want that abdomen to expand. Now, you also want the patient not to be able to harm you. So you want to make sure they can't bite you, claw you, anything like that. At Ada County, we have spit hoods, which are specifically designed for this. But just because you hear about spit hoods, don't do something silly like putting a bag over their head. And I've seen that done. I've seen pillowcases duct taped or medical taped around somebody's head. You can't assess them. You can't manage their airway that way. So if you don't have a spit hood that's specifically designed for that purpose, don't improvise one. You have to be able to monitor their vital functions, which includes their airway and management. You have to prevent, once you decide to restrain them, prevent running, prevent them from getting out. So make sure they can't undo their seatbelts and suddenly jump up. Sometimes you can turn them upside down. Some agencies have specific buckle guards to prevent the patient from engaging them. It's always a good idea to keep one person between the patient and the door. Just having a person there can dissuade somebody. Now, this is a big one because there have been some cases where this has gone south. Is if you actually have handcuffs on a patient, actual handcuffs for some other law enforcement initiated restraint, the officer has to be in the ambulance with you, not falling behind, not, oh, I'll meet you at the hospital, actually in there with you. And the reason is and they have to have the right cuff key to undo the handcuffs. I was actually surprised. Apparently there are different handcuff keys for different types of handcuffs. And if one officer put his cuffs on the patient and it's a different officer with a different cuff key riding with, that does you no good. The purpose of the officer there is to disengage the handcuffs in a quick manner so you can provide emergency resuscitative care. So let's talk about pharmacological agents. And there's a key principle I want to briefly discuss. I can't remember if I have it later on this slide. It's not a progression between physical restraints and then if those don't work, then pharmacological restraints. In probably 75% of the cases, pharmacological restraints actually make physical restraints safer because the patient no longer struggles against them. Now, the big one, the go-to standard is benzodiazepines. Now, the problem with benzodiazepines is that they are respiratory depressants, but they also decrease agitation, which in turn increases or decreases your oxygen deficit, which improves oxygenation. So all in all, it's a net gain. And they're predictable. We know how they work. And they also have seizure suppressant capabilities on your seizure threshold, all of which are advantageous in the pre-hospital setting. Now there's another drug that we use for sedation called haloperidol. Now, a lot of people love it. I'm not a big fan of haloperidol because it does have some adverse interactions with certain medications, particularly methamphetamine and similar stimulants. It can have adverse reactions such as your EPS symptoms. Imagine right in the middle of your combative patient, they also start having EPS, etc., so forth. Still, it's effective. So it may be what you have in your protocol. I know that where I came from, because they really locked down your narcotics hard, is most providers would only give Haldol because the administrative burden was less. I'm fortunate we don't work in one of those systems. So Haldol is acceptable. It's very old school. It's not my personal first choice at all. If you give Haldol, give some Benadryl. Not only does Benadryl help mitigate the adverse incidence of EPS, it also potentiates the sedative properties. I also recommend, if you have a way to do it, given an antiemetic such as Zofran. The last thing you want is these patients being restrained and then suddenly start vomiting because of the other issues they have going on. Now, I'm going to add one moment of caution here, is that it depends on your antiemetic. If your antiemetic is Phenergan, for example, Phenergan has very potent sedative properties. So you want to be cognizant of what your safety profile of your drug is, so that if you give it, you're not making yourself in a position where you have to hold the patient's airway open. You know what I'm saying? So be cautious with that. Know what your cocktail is going to be, so to speak. Another one that we used to give, I don't have it on this slide, but it's an absolutely amazing chemical restraint, is anapsine. And it may be coming back. So if you see that return, it's a great chemical restraint. Now, a lot of agencies, now this is at Ada County, a lot of agencies use ketamine. We don't, for patient restraint. I'm hopeful that we might hear in the near future, but that's neither here nor there. But the problem with ketamine, so ketamine is a great drug. You can use it for pain, you can use it for induction, you can use it for all sorts of different things. The challenge with ketamine is that when you give it in the restraint-related context, not for RSI, which you give it via the intravenous route, not for pain control, which you give low doses, hopefully via the intravenous route or the IM route, but in order to get them rapidly under control via the IM route, which is when you'd give this. This is the guy you're holding down, he's struggling, you're trying to get him restrained, you're going to stick him in a large muscle mass. In order to do that, you're going to need to give a dose somewhere around 5 milligrams per kilogram. This is the upper end of its so-called safety profile. The problem with this is that depending on the study you read, and this is debatable, depending on the study you read, when you get up around 4 to 5 milligrams per kilogram, your incidence of needing to intubate the patient skyrocket. And keep in mind, if you have to intubate them, you are intubating them not because you want to, but because, in this context, but because you have no choice. It's not the position you want to be in, and it's, is being forced to intubate somebody on the disease process's terms, not on our terms. So That's the problem with ketamine. Now, it is still a great drug for chemical restraint. It's been used very effectively for it. But you need to be aware that if you are allowed this in your protocol, and if we ever get at Ada County where we're allowed it, you need to be aware that when you give your chemical restraint doses, your safety profile, your risk benefit is a different animal than when you're giving it for, say, pain or something else. So be very cautious of that. It's not currently in Ada counties, but might. And this is what we're talking about, is a 30% intubation rate. Also understand that there is a little bit of a political stigma in this. Last year, Minneapolis police, there was a big deal. It became a civil rights issue. There was some body cam footage where cops dealing with a lot of combative patients were like, oh yeah, here come the paramedics, they're going to bring the good juice. And their statements were taken out of context. And the result of that is that, basically is people assume cops were telling paramedics how to do their job. They got their ketamine pulled. They're doing a very great study. They got their ketamine pulled. Civil suits were threatened. It ended up being a huge nightmare. And paramedics lost one of their best tools to deal with combative patients in an area that had a lot of really severe drug use and a lot of combative patients. So the moral of the story is, keep in mind, everything you do is on scrutiny. Everything you say is admissible. Cops almost always have the body cams. They are probably on during these situations. People have their cell phones out. Make sure that you are above reproach in these situations. Do not present the image of a crazy paramedic, cowboy paramedic, who just walk in, dart him in the butt, and everything's going to be fine with your magic juice. Present the image of a thoughtful, diligent paramedic who is making the best choices, not in the benefit of law enforcement or yourself, but in the benefit of the patient. Now, even when things go right, they can still go wrong. And this is a great video, but I'm not going to show it here. I'm going to show it separately because the audio doesn't come through very well with this program. So take a watch of this video. And this is a video that I actually use frequently with my street drug lecture also. But it's agitated delirium with restraint and how quickly they can go south. Keep in mind that patient restraint monitoring and keeping it, we talk about every 5 minutes for critical patients. This is an every minute thing. You need to be on top of your game. There are plenty, and I mean more than a few, quite a few, a lot of documented case reports of patients going from screaming to cardiac arrest in 2 minutes or less, caught on body cam, and you'll see that in the image or in the video I'm going to share. So pay particular attention. Now there are 4 big H's that will kill these patients. Hypoxia, which is why we want to make sure that not only are they able to expand their chest to move air, but we give them supplemental oxygen. And if they won't tolerate a nasal cannula, blow by oxygen, oxygenate them, and document it. Hyperthermia is the other one. Remember that the higher body temperature, the more oxygen demand. The lower body temperature, the lower the oxygen demand. If they're fighting, their body temperature is skyrocketing up. So take the fight out of them. Allow them to cool down. Hand in hand with hypoxia is hypercarbia. Again, we want them to offload that CO2. The more acidotic they get, the less our medications work, the more irritable the heart gets. The more that they can offload CO2, the acidosis will correct itself, the hypoxia will correct itself, the better off they'll do. So worry about those 4 H's in every single one of these patients. Otherwise, you're going to be faced with cardiovascular collapse, which will in turn degenerate into cardiac arrest. And the other one, not really related to these top 4, the other one I want you to keep in mind is, of course, distal PMS. Make sure they're not breaking their wrists, breaking their ankles, struggling against your restraints. Make sure you document it. So again, going back to the ACEP 2007 paper, restraint should be carefully documented, including the reasons for restraint. And don't just say, they were combative, I restrained them. Patient demonstrated this, and this. Patient said, I'm going to get you, sucker, and did this, this, this. Whatever the case is, document clearly. Quotes are good. Somebody say, well, I don't want to document when patient says F you or whatever. In this case, it shows intent. It shows the mindset. Quotes are good. Yep. So things not to do. Don't do chokeholds. There was actually a case in Kentucky. I know the medic fairly well. He was a decent medic many years ago, who got wrapped up into restraint of a patient in the drunk tank at the local jail. And it was a knockdown tussle. Now, the sheriff's deputy's been tussling with him for about an hour before he got involved. But the bottom line is, at the end of the day, when they reeled in to help keep this big behemoth of a guy restrained, he had him in a chokehold on the gurney, trying to hold him down. Or what was perceived as a chokehold. Well, at that moment in time, when they transferred him over, the patient coded. Now, did he code from the so-called chokehold, or did he code from the hour and a half of struggle, the cardiovascular collapse, the 4 H's we talked about beforehand? Probably those things. But what do people remember? What got documented? What did the news at the court case focus on? The chokehold. So just don't do them. Keep in mind that just because we're restraining somebody doesn't mean we're not providing medical care as well. Oxygenation, ventilation, etc. Now, runners are a problem. Runners are a problem because what we're faced with is somebody who we've assumed a responsibility for, but now they want to leave. Now, if they are in custody, if they're being detained, if they no longer have those rights, then guess what? Somebody with the legal authority to detain them should be in the back with them. Our policy at Ada County, as debatable as it is that if they want to run, we let them. I would personally admit in that policy to say, let them when it's safe to do so. So, a lot of times you can discourage them, so on and so forth, but if I'm going 55 miles an hour down the road and the patient wants to leave, I'm going to try to stop them because I know that I have an obligation to do so, because if they jump out at 55 miles an hour, they're going to hurt themselves if not die. That's, I've created a responsibility for that. If I'm parked and they want to run and they're not being detained by a law enforcement officer, that's a different animal altogether. Review your policies, know what your local agency's policies and practices are, but keep that in mind. So if there's any questions, you know where to find me in the discussion board, the ungraded Q&A discussion board, and I'll see you out there. And don't forget to watch that video.